Hello, everybody. Thank you for coming to the webinar. Today we are going to talk about diabetes mellitus and the psychopharmacos, that is psychosis, depression, and anxiety. So let's start. Talking about diabetes mellitus, the definition of diabetes mellitus are a group of diseases. So it's not only diabetes type 1 or diabetes type 2. There is, we classify 4 types of diabetes that we are going to see today. And characterized by hyperglycemia, you need to start remember what are the normal values of glycemia in a person who is not diabetic. And abnormalities in fat. We have carbohydrates, proteins, and protein metabolism. So just to make a small summary on that, if you cannot use the glucose, you're going to start using fats and proteins, right? All right, so what happened with the chronic hyperglycemia is that it will be some long-term damage, especially on vessels, eyes, and of the eyes, kidneys, and nerve. That's why diabetes mellitus in the long run, what produce is a narrowing of the vessels that give blood supply to sensitive areas like the retina. So the patients start to lose his vision, get blind, and kidney can get into kidney failure because the glomeruli, the vessels is narrow, and that produce kidney failure. So mostly of the kidney transplants are being caused by diabetes. And neuropathy. Neuropathy, the patient is telling you that is walking over cottons because they are losing sensitivity, especially on the distal portions of the upper and lower extremities. All right, so let's keep going. So here we are going to see some about the incidence. Just a few words about this is that we have 23 million people of prevalence, so old and new cases. And we have, I want you to read that those slides I just prepared today about higher risk for diabetes mellitus type 2 and what are the higher risk and incidence in the United States. One thing, what is the cause of diabetes type 1? We don't know. It's unknown. What is the cause of diabetes type 2? We don't know neither. But definitely what we know are what are the factors related to diabetes type 1 and diabetes type 2. In diabetes type 1, you already know that there is no insulin at all because it's an autoimmune disease that is being destroyed the beta cells of the pancreas. And diabetes type 2 is the resistance to the insulin. So and we will see that the medication of diabetes is a little bit complicated. So what I was trying just to make it easier and make a synthesis about that. Okay, so let's start the normal value. Normal value in, from a person who are not diabetic. We have fasting 70 to 99 milligrams per deciliter, and patients who are not fasting should be less than 125 milligrams per deciliter. So that is the normal values, and we are going to see what is the diagnostic values for the diabetes, DKA, diabetic ketoacidosis, and the hyperosmolar coma that is mostly in diabetes type 2. All right, so let's keep going. So here we have a summary of the David, thank you for coming. I see you. We have diabetes type 1, diabetes type 2, gestational diabetes, and other specific types. So we have how many types of diabetes? We have 4 types. Number 1, cause is unknown. Type 2 is resistance to insulin. And the treatment is going to be insulin here. Here is going to be oral antidiabetic. We have the gestational diabetes that is an abnormal increase of glucose in blood. The patients can receive insulin, but no oral antidiabetic medication is contraindicated. We have other specific type of diabetes. For example, we have endocrinopathies We have, for example, tumors of the adrenal gland that produce increase of levels of cholesterol or cortisol, sorry, and increase the glucose in blood. We have acromegaly. The acromegaly can actually produce resistance to the insulin. Another, for example, genetic syndromes, where it's very common to see patients who are, for example, Turner syndrome, 45X0, they develop diabetes type 2. Another Down syndrome. Down syndrome it's very common to see these patients with having these problems. All right, so we have how many types of diabetes? We have 4 types. So here we have for diagnosis of diabetes mellitus, we are going to see that we have the hemoglobin A1C. Hemoglobin A1C. There's many questions for NCLEX here, and please pay attention to this. Is that one A1C is it's a test based on the activity of the glucose in the hemoglobin. So this keep as a memory of how was the activity of the glycemia of the patient in the last 3 months. So why is important that? Because we want to know if there is adherence of the patient to the medication, to the insulin or to the oral antidiabetic medication. So in this history of 3 months, you're going to tell if the patient is being strict or is accurate with the medication every single day. All right, so just to another thing is that we have diabetes mellitus and signs and symptoms and causal plasma glucose. So that means at any time, doesn't matter at what time of the day, random, that diagnosis is going to be diabetes when it's more than 200 millimeters or milligrams per deciliter. Or in fasting plasma, when is the glucose more than 126 milligrams per deciliter. We have the 2-hour plasma glucose. So after 2 hours, you take the sugar. We have 75 grams of sugar. After 2 hours, if the sugar is more, glucose is more than 200, that is actually criteria for diagnosis of diabetes mellitus. So in conclusion, just remember those numbers. So first of all, what are the normal values in a normal person? 70 to 99 in fasting. At any time, no fasting is going to be less than 125. Less than 125. Here, in diabetic patients, we have A1C more than 6.5, 200 and 126. So those are the values that you need to remember. Remember, at any time, 200. Fasting, more than 126. And 2 hours plasma glucose, more than 200. So those are the values that we need to handle. And what could be the goals of the range of glucose that we need to have in blood for a diabetic patient? According to the American Diabetes Association, recommend fasting blood glucose between 80 to 130 milligrams per deciliter. You know that the normal values for a normal person is 70 to 99. But that is the value, that is the range of glucose that is recommended for patients who suffer from diabetes. All right, so let's keep going. We have diabetes complications. Diabetic complications is microvascular and macrovascular. So what I want you to remember is this. You will understand all the pathophysiology of the diabetes with a simple thing. Number one, you have the vessel. The vessel, remember, have the endothelium, the tunica media, and the dentition. Okay, we have blood inside. What else we have? A lot of glucose, the glucose. So the glucose is going to make more thicker the blood. That is simple to think. But there's another thing happening there. The thing that is happening is the glucose is a substance is going to react with the endothelial cells, so the tunica intima. So what is going to do is a reaction of the tunica media, and that produce hypertrophy of the tunica media, so the muscle. The tunica media is going to be hypertrophy, increase in size, making the lumen of the vessel be smaller. So what happened with the blood supply, what happened with the perfusion is going to go down. And especially where the vessels are very tiny, especially in the distal portions of the upper and lower extremities, is the one who will suffer the the consequence first. Another vessels that are very tiny, and because of this narrowing of the vessels, because of the glucose reacting with endothelium, that is in the retina. And the kidney, we have the glomeruli, the efferent and the efferent. So these vessels are going to be very narrow in the long run with diabetes. And what happened? They have low perfusion. So we have kidney failure in diabetes. So number one cause of transplant in the United States because of diabetes, kidney transplants. We have blindness. Diabetes produce blindness because the vessels in the retina are going to deteriorate or degenerate the retina. And the nerves. The nerves distally in your upper and lower extremities, they need to receive blood supply too, right? And these vessels are because distally are very, very, very small diameter. So less oxygen, the nerves start to degenerate, start to lose sensitivity of upper and lower extremities, and you start to feel that you're walking, for example, over cottons. And that means that you lose sensitivity. Okay? Plus, it's not the only thing that is happening in the whole body. The vessels who are going to, for example, the nerves that are going to innervate the GI tract. If you have innervation of the GI tract, the vessels, they need blood supply. But this narrowing of the vessels produce that these intestines are not going to have this innervation. So some nerves are going to die. So you start to have, for example, constipation because the nerves are not sending information or impulses for peristalsis, for example. Or you have a lazy gallbladder because the gallbladder will not respond because how they contract with the nervous system. And these nerves are being degenerated. So it's not it's not kidney, retina, and nerves only. It's mostly all the systems are going to be affected. Okay, so let's keep going. So nursing diagnosis, we have risk for infection. Why risk for infections? Number one, please, I want everybody, well, two of you, remember that when you have high levels of glucose, one of the things that is happening is that the activity of the white cells are going to be diminished. So the white cells are not going to respond effectively and faster when you have some bacteria present. So immune system go down in that case. Risk for infection. For example, what is the most common infection in diabetic patient? Number one is the urinary tract infection. Urinary tract infection. Why? Because the urine contains glucose. And what the bacteria like is glucose. So it's going to be a culture. So it's very common to see these patients with UTIs. Another thing, the third example is we have 29 million people, almost 30 million people having diabetes all over, diabetes type 1, type 2, and other diabetes, about 30 million. From this, we have 7 million that they actually don't know they have diabetes. So there's a difference between diabetes type 1 and diabetes type 2. Remember that diabetes type 1 can happen at any age nowadays. And diabetes type 2 happen at any age too. The symptoms are going to be, as you know, the polyphagia, polyuria, etc. in the diabetes type 1. But in diabetes type 2, the signs and symptoms are going to be a little more kind of difficult to detect at the beginning. So it's going to be a slow progression. And one of the things is going to be urinary tract infection. Another thing that can happen for risk for infection is fungi. You have yeast, vaginal yeast in women. And just remember that diabetes type 2 is mostly happen in female, more than male, female, older than 45, another F, 45, is going to be family history, another F, okay? And those are actually the population who are more in risk for to have diabetes type 2 in the United States. Another group is going to be the African American population and Hispanics, so Latin American people. Okay, so we have risk. So risk for infection is very important. Risk for disturbed sensory perception. You can tell that mostly affected are the distal portion of the upper and lower extremities. We explained that. Imbalanced nutrition, less than body requirements. So the patient is afraid to eat. The patient is doesn't know really what is better, what is the plan to eat. And I tell you ahead of time, the diet for diabetes is going to be your 40, 30, and 20%. 50 carbs, 30 what proteins, 30 fats, sorry, and 20 proteins. So 50 carbs, 30 fats, and 20 protein. So that means a balanced diet, And of course, is going to be regular exercises. All right, so we will talk about a little bit more about that. Deficit of fluid volume. Why? Because the patient have polyuria, right? So if you have polyuria, they will have a problem with dehydration. Fatigue, of course, they don't have enough glucose in order to use for energy. All right, so that is about nursing diagnosis, just to make it simple. Patient education, patient teaching, they need to know that is NCLEX, teaching patients to self-manage all the aspects of their disease is the most important. He's not going to have a nurse or a doctor all the time, so they need to handle the situation by himself or herself. So teaching patient is critical for this patient's success in their treatment. So the diet we was talking for patient is about, for a normal average person is about 2,500 kilocalories per day, but in patient with diabetes is about a little bit less than that, 1,500 to 2,000. Just remember that 95% of the treatment for diabetes is going to be diet. Carbohydrates, 45 to 65, average 50%. Proteins, 10 to 35, average 20%. Fats, 20 to 35% of my plate. Remember, my plate is not my plate, it's the term, is about 30%. Okay? All right, so another NCLEX question, very important, please. The patients, now, can you tell me, please, I don't have audio. I don't know if everybody's listening me. Okay, so just a moment. Okay, I don't know, Joan, can you hear me? I'm not sure if you're listening. So, all right, so I have 100% of audio right now. So thank you for coming, Joan. Okay, so here, patients. So you can tell me, I cannot hear you. I don't know what happened anyhow. So you can tell me why the majority of the patients with diabetes have hypertension. Why the patients with diabetes have hypertension? The 99% of the patients are going to suffer from hypertension. Why? Because that's what I explained before. So the reaction of the glucose with the endothelium produce a thickening of the tunica media of the vessel. That is going to narrow the lumen of all the vessels in all the body. We was explaining about the retina, the kidney, and the blood, the vessels who give blood supply to the nerves, right? Neuropathy, blindness, and nephropathy. In this case, it's going to decrease the lumen, so obviously you can tell me is the increasing of the peripheral resistance because of that cause. And this is going to have a problem that for forever, because the peripheral resistance is going, and the patient needs to receive medication for that. So, but you can tell that we was mentioning about hypertension without diabetes patient, what is the ideal blood pressure that we need to keep. The patient is below 140 and over 90 millimeters of mercury. But if the patient is diabetic and in addition is hypertensive, you're not going to have that range, so even less, because you want to be in a very safe place in order to prevent complications. And that blood pressure in diabetic should be kept in less than 130, not 140, 130 over 80 millimeters of mercury. So that even less than a patient who doesn't have diabetes but hypertension. All right, so in this case, we have diabetes plus hypertension is this value, okay? All right, so maintain the BMI less than 25, so we don't want the patient obese. And one thing very important is stop exercising if the patient is feeling weak or dizzy. Okay, so what is hypoglycemia? What is hypoglycemia? I have a problem with the audio, I guess, so it's being cut or I'm not sure what's happening. So let me see if I... Okay, can you hear me now? Joan, you can hear me now, right?
Yes, I can.
Yeah, the sound is okay?
Yeah, it's okay.
Okay, thank you.
Mm-hmm.
So you're the only one who can, I could open the microphone. All right, so let's keep going. Hypoglycemia, please don't forget that, hypoglycemia. Hypoglycemia is less than 70 milligrams per deciliter. So any level of less than 70, equal to 70, is going to be hypoglycemia. Okay, so what are the signs and symptoms of hypoglycemia? So that is NCLEX question, so please, this is very important. First of all, the patient is going to suffer from hunger. It's hungry, right? It's going to be hungry. It's going to have some apprehension, so that means that it's irritable. It's very sensitive, so become nervous. I have tremors and sweating. So you need to remember about the patient is hungry, apprehension, and they have some problems of double vision. All right, so now, so what happened in this case? What you're going to do? You're going to give candies, sugar, fruits, juice, something that is going to be sugary, and that is going to increase the glycemia of the blood. But the problem is when the patient is unconscious, what you're going to do? In that case, you're going to we can give fluids of with 50% dextrose that is going to increase is going to resolve the hypoglycemia, or giving glucagon. Glucagon that is going to be another way to rescue the patient from hypoglycemia. All right, so let's keep going. All right, so now we are going to talk about hyperglycemia. Hyperglycememia. Question for NCLEX again. What is hyperglycemia? What is the most common cause of hyperglycemia? All right, so those people who don't take the insulin, those people who are missing a medication for oral antidiabetic or the insulin. So those are the guys who are going to start having increase of diabetes, hyperglycemia, and produce coma, right? Remember one thing, please. Diabetic type 1 is most commonly to have DKA. I say DKA, diabetic ketoacidosis in diabetic type 1. And diabetic type 2, the most common is hyperosmolar coma. Hyperosmolar coma in diabetes type 2. So if you can write down this, because it's going to be useful. In diabetes type 1, so we have DKA, and it's considered that you have DKA when your glucose is equal or more than 250 milligrams per deciliter. 250 milligrams per deciliter. That is diabetes type 1, DKA more than 250 milligrams per deciliter. And in diabetic type 2 is the hyperosmolar coma, that is you have the glucose more than 600 milligrams per deciliter. Okay? All right, so one thing that we need to remember that the requirements of hypoglycemic medication or insulin are going to change according to the stress. If the patient is going to have is going to be under stress, the sugar is going to go up. How is going to go up? Number one, cortisol is going up. So cortisol, remember, is going to produce increase of gluconeogenesis, producing release of glucose into the blood. Second, you have adrenaline and noradrenaline. Those are the fight or flight hormones. And what they are going to do is to take glycogen from the muscles and liver and put glucose in blood in order to have more energy to fight or flight, right? So that stress. So what stressors we have? Pregnancy could be one. Surgery, infections. So infections are stressors. So for this, that's why patients, they need to have a close control of the glucose. All right, so let's keep going. Symptoms of hyperglycemia, we already know it could be the PPP, the polyphagia, polyuria, polydipsy. In addition to that, one of the most common is going to be rapid pulse, headache, okay? Rapid pulse headache. So that is the initial symptoms of the hyperglycemia. Then you start to have acetone odor. That acetone odor. What is acetone odor? Acetone odor. That means if you are hyperglycemic, that means that all sugar is in your blood. It's not in the cells. So the cells are still hungry. They are going to start using fat. And when they're using fat, they obtain a lot of energy, but the negative things is that they produce ketone bodies. These ketone bodies, they have three components. One is the acetone. So this acetone is the odor, is like pungent fruit, rotten apples that you can smell, not putting your nose in his mouth, her mouth, but about 3-4 meters away. You can, or 3-4 yards, you can start smelling this strong odor from the mouth. Okay, so that means ketone bodies, in other words. Coma and death. Treatment is going to be administration of fluids, insulin, monitoring blood glucose, ketones. How we are going to check ketones? It can be checked by the urine. Urine ketones are going to, if you have a lot of ketone bodies, the ketones or ketone bodies are going to be eliminated by the kidney and urine, and you will find them. And potassium, hey, very important potassium, right? Potassium. If you are going to administer potassium, insulin to the patient in this case, so and they have hypokalemia, basically the patient is going to have a heart attack. So you need to normalize the levels of potassium. Why? Because glucose is going to enter with potassium into the cell. So if you're going, so you need to be careful that the electrolyte balance on the patient. All right, so let's keep going. Let's go close to the, make a summary of the medications. That is very important, but this is endless because there's a lot of nursing considerations here. The insulin is going to be administered before meals. How early? It could be 10 minutes early or 5 minutes early, 15 minutes early is about what the insulin is going to start, because we have a combination of insulin, and the onset of insulin is going to take the earliest about 15 minutes, right? 15 minutes. All right, so we will see that in a few seconds. All right, so if, by the way, the oral anti-diabetic medications, NCLEX, they need to be taken half an hour before, with one exemption that we are going to see at the end. So mostly all medications need to take it half an hour before. Now, what happens if you skip the meal? You skip the pill, okay? So you skip the meal, you skip the pill. All right, so insulin. If mixing insulins in one syringe, the clear, that is the regular, or the rapid, regular, and then we have the rapid, the other one that is are clear, and they are going to be the long-acting is going to be cloudy. So we are going to see that now. All right, so first of all, clear and then you are going to withdraw the cloudy insulin to mix it, right? Rotating injection sites avoid atrophy, hypertrophy, lipodystrophy. So this is another question for NCLEX. The lipodystrophy. Lipodystrophy is lipo is fat, dystrophy is atrophy or some changes on the lipids under the skin. So this is these fats become like a little bit rubbery if you touch this lipodystrophy, because when is that happen? When you don't make rotation of the insulin. If you don't make rotation of the insulin and you are injecting the same area, the fat under that area is going to become atrophic and become rubbery. So what means that the absorption of the insulin is not going to be effective. The insulin is not going to be absorbed. So that's why we need to rotate the, so how long we need to take for rotation? About a week. And how, as you, for example, you pick up, select the right arm, for example, after 1 week, you 7, 8 days about, you are going to go into the other arm, other extremity, and rotation. And the injection should be no at least one from each other, a ½ inch to 1 inch distance from the previous injection in order to prevent the lipodystrophy. All right, so we have the rapid and short insulin are clear, and cloudy is going to be the long-acting insulin. Okay. All right, so once the how we store the insulin? The insulin is open. We need to store in room temperature for you can store at room temperature when it's opening about 1 month. It is going to lose potency at higher temperature. If surgery may need more insulin undergoing surgery. Why? Because stressful. The stress is going to increase cortisol, adrenaline, or adrenaline, increase the sugar in blood. We need to date the insulin, so at the time it's opening, we cannot freeze it. Don't shake the insulin, you need to roll it. So we cannot shake it, the insulin. So you roll it in your hands and warm it up in order to dissolve the powder. All right, so let's talk about the type of insulin. We have the rapid acting is the Novalog. So this called the analog insulin is the rapid acting, and why analog? Because the name is Novalog, Novolog, Humalog, Lispro is the most common. So here, brand name. Here we have the onset and the peak. So when you're onset and peak, so we have the rapid. We have, remember, log, everything is rapid going down the hill, like the log going down the hill. Short acting, we have the fast acting. So we have Humalin R, Novalin R, and they have the onset about 1 hour and the peak is about 2-3 hours. So this insulin can be is actually used as IV infusion. So even intramuscular, but the rest is subcutaneous. This can be subcutaneous too, but this can be given, is probably the only one that we use for IV or IM. Another question for what? For NCLEX. And it's used for DKA and coma, as we can tell that is the route we use. Intermediate, we have intermediate Humalin N. So the previous Humalin N, Humalin, but this Humalin R from short acting, and intermediate is Humalin N. So everything is N. All right, so the long acting, we have the Determir or the Levemir, the Glargine, Lantus, LON. Glargine is used as a basal dose, not as a bolus with meals. What is a basal dose? Basal dose are, listen, this is very important too. Pancreas is not releasing insulin only when you eat. No. The pancreas is going to release insulin the 24 hours. It's going to have peaks of release of insulin after meals. It's true, but the pancreas never stop working. They actually have some always levels of insulin secreting the 24 hours. So they have peaks in the what at night. So this is what we call the basal dose. So basal dose, a patient who has diabetes type 1, if we trying to make a physiologically work like physiologically normal, to give a baseline uh, of insulin, and this Lantus is going to last about 24 hours, right? So that is actually what is the base. So on the top of that, according to the meals who are being planned by the doctor or by the patient, they are going to administer the rapid and the intermediate or regular insulin according what the patient needs. So that's why we combine rapid or fast with a short, sorry, and the intermediate or the intermediate, short, and rapid. Okay. So now the intermediate insulin is the one who is more closer of what the insulin is produced by the body. Okay, so here we have the onset, peak, and duration. So please, I want you to remember this, that the peak is the risk for hypoglycemia. The peak is the risk for hypoglycemia. You have a rapid Humalog, the onset is 50 minutes. You must know that 50 minutes, because if you can see, is the earliest that you have effect with this insulin. So the peak is about 60 to 100 minutes. In NCLEX, they are going to ask you when you're going to give the candy and sugar, whatever. So mostly they pick up the 120, so 2 hours. After 2 hours, you're going to have this hypoglycemia. Short acting, 3 hours, so 2 hours, 3 hours, and the other one, intermediate, is about 12 hours, okay? Every 12 hours. Okay, the long doesn't have peak because it's 24 hours. All right, so here we are going to see who gets insulin. Outpatients, all patients with diabetes type 1, and patients with diabetic type 2. Patients with diabetes type 2, when the hemoglobin A1C is more than 9.0, so normal is 6 for normal person, 6.5 is already elevated, so 9 is a patient with diabetes type 2, right? Is going to be able to receive insulin. In patients with DKA, remember that DKA is equal or more than 250. So what means DKA? So at this number of glucose in blood, you start to produce ketone bodies. That's what does it mean. And ketone bodies, what is that? Is acid. And what is going to lead to? Is going to lead to what? To metabolic acidosis. Metabolic acidosis. That DKA is very common to have in patients with diabetes type 1. Hyperosmolar coma is very common to see in diabetes type 2. And the sugar, glucose, is going to be higher level, about 600 milligrams per deciliter. All right, so let's talk about the oral antidiabetic medications. So it's the time to talk about the meds. So listen, oral antidiabetics, you know, insulin, what it's doing is to put the glucose in the cell, inside the cell. So the glucose levels are going down, right? So that is the mechanism of action of all the insulin. Ones are going to be faster than others, but in general, the mechanisms is that. But in oral antidiabetic is different. So we have, for example, we have oral antidiabetic medication that imagine a patient who has high glucose in blood, diabetes type 2. So how do you want, or how do you think the body is going to try to decrease the, to return to normal values? If you have more sugar in blood, so you are going to produce more insulin. Now, if you have too much sugar in blood, the liver is not going to produce the glycogenolysis. So that means that the glycogen turns into sugar and glucose. So that is going to be stop. Then the body, what we like to do, decrease the absorption of glucose. And what else they can do is going to actually decrease the glucagon. Why they decrease the glucagon? Because what is doing the glucagon? Glucagon is the opposite of insulin. It's taking sugar, glucose from the cell to the blood, and that's what we don't want. So those are the four mechanisms of action of the oral antidiabetics. So, so for every angle that you can see how you can decrease the glucose in blood, that is the mechanism of action that we have in the medication. So we want to decrease the glucose, we increase insulin. We decrease the glucose formation from the liver and muscles. We decrease the glucose absorption and we decrease the glucagon. So those are the four mechanisms of action. So for this, we are going to have some nursing considerations. For example, if you have diabetes mellitus and you have the patient is under prescribed by NPO, but the patient is diabetic and he needs to take the pills, right? So what to do? So because why is that? It could be, for example, the patient is NPO because they need to have some lab tests, or they need to have some endoscopy, or a colonoscopy, or some procedure, and the patient is actually not even taking water, because NPO means not even water, no water, not even water. And diabetes mellitus plus NPO, so what you need to do is to contact the health provider, okay? What they are going to do is they are going to order a sip of water with the medication, or decrease the dose because the patient is not eating, etc. So it depends the situation. But what you need to do as a nurse, diabetes mellitus plus NPO, need to make the medication, you need to contact the health provider. All right, so we have oral antidiabetic. We are not going to give it to pregnants. We are not going to give to pregnants. Why? Because pregnants, the oral antidiabetic is passed to the fetus, and the fetus is not diabetic. So what you're going to make the patient, the fetus is have hypoglycemia. So we don't want that. Instead of this, we are using the insulin. The insulin is insulin. The question is, they pass the placenta? Yes, but a little bit, but not enough in order to affect the physiology of the fetus. So insulin, pregnant with diabetes, they are going to be treated not with oral antidiabetic, but with insulin. Okay. All right. So here we have the four forms of mechanism of action, and here I classify for this class the whole group of oral antidiabetic. We have the sulfonylureas. Just a moment. Okay, so we have the sulfonylureas and similar. So we have the incretins. All right, so listen. Okay, so what is the sulfonylureas? Sulfonylureas, what is doing? Increase the secretion of insulin. Incretins, what is doing incretins? Incretins is a group of medication. Incretins are going to increase the insulin. And we have the GLP-1, GIP-1, and DPP-1. And what they are going to do is they are going to actually increase the production of insulin. So is GLP-1 is the glucagon-like protein, and that is going to have effects of, it's called glucagon, yes, but they are going to actually it's called like that because the protein is similar to that hormone. But what they are doing is to increase the levels of insulin. Incretins, GLP-1, GIP, and DPPI. So this is an enzyme that is going to make increase the insulin. We have decreased the glucose from liver and muscles, that we have the metformin. It's not metformin, it's metformin. I forget the F there. We have the thiazolidinones, and we have glucose absorption. We have the alpha glucosidase inhibitors agents that are actually the acarbose and miglitol. And we have the glucagon, decrease the glucagon. Glucagon is the amylomimetic agent. So this is not the names I want you to remember, but this is the classification that you are going to know. So I'm going to make it more easier than this. All right, so we have the first group. Okay, let's go back. This is the first group. Okay, insulin secretion, increased insulin secretion. So what we have two sulfonylureas, similar to sulfonylureas is another group, and the incretins. So we have three groups in the increasing of insulin. So what I want you to remember is this. Sulfonylureas, similar, and incretin, right? So sulfonylureas is going to have sulfur. Number one, it's allergic to sulfurs, so you can stop the medication. All right, so we need to remember first generation, second generation, tolbutamide, propamide, gluburide, glipizide, and this the rapaglinide. So do you need to remember all the names? No, I don't think so. You need to just get familiar with the names. Why? Because number one, for example, all these oral antidiabetic medications that we saw, this is the previous slide, for example, they need to be taken, except one, 30 minutes before. They have some side effects that we are going to see right now. All right, so here we have, please pay attention on this, okay? You know, these are very important. We have first generation and second generation. Why is first generation? They have less side effects. So common side effects for both of them are the for first generation sulfonylurea, and second generation are going to be nausea, weight gain, and hypoglycemia. So the second generation, they have less side effects. So they are minimizing the side effects that we have here. So the most common question for NCLEX. Number one, first generation is one of the first medications being used the other ones was the metformin, but this sulfonylurea is one of the first, it's the first sulfonylurea being in the market, is the Diabinese. So Diabinese, first generation, produce nauseous, weight gain, and hypoglycemia. Hypoglycemia, sulfonylurea, so that you need to remember that. Number one, we need to have, they're going to have hypoglycemia. Okay, so nauseous and vomiting. So here, please, just pay attention. Diabinese is going to produce the anti-abuse effect. If you mix with alcohol, anti-abuse effect, if you mix it with alcohol, they are going to produce nauseous, vomiting, and headache, etc. But definitely the patient is going to be really miserable with this anti-abuse effect. So don't mix it with alcohol. The weight gain, so please don't think about edemas. It's not accumulation of fluid. It's going to be because the insulin stimulation. So the sulfonylurea, what is doing the sulfonylurea is going to increase insulin secretion. Remember one thing. So is diabetes type 2 is resistance to the insulin. Okay, so all right, we're fine. It's resistance to the insulin. But not all cells, so there's a big majority of cells who are resistant, but not all cells are going to be resistant to the insulin. So it's going, that's why if you have resistance to insulin, if you give more insulin, you have more options. It's more likely that the glucose is going to keep going into the cells. Okay, so weight gain because insulin is going to make you accumulate glucose, glycogen, etc. Right? So that is why you are going to gain weight. Hypoglycemia. So please, this is very important. So because there's other medications that do not make, the majority of oral antidiabetic produce hypoglycemia. All right, so take 30 minutes before breakfast. So all the, except one, are going to be taken 30 minutes before. So sulfonylureas, or what else is going to make you think about that? If you're allergic to sulfas, remember penicillin, number 1 allergies, number 2 cephalos, and number 3 is going to be sulfas. So if you are allergic to sulfas, sulfonylurea, so it's going to be very suggestive, is going to have a cross reaction. Diuretics, the thiazides, they have sulfur too, and they can produce a cross reaction. All right, so we already told, let's go back to the slide. So we have first generation, second generation. Let's go to the similar to the sulfonylureas. The similar to the sulfonylureas, we have this and this. We don't want to remember those names, but these are the one. Prandin, Starlix, those are the commercial. Repaglidine and natglidine. Okay. Yes, we can create some mnemonics here, but what they are going to do, first of all, is increase the, they are similar to the chemical, to the sulfonylurea, so that's why it's classified here. So what they are doing, what is remarkable here is that produce hypoglycemia. So all the sulfonylureas and similars are going to lead into hypoglycemia. This is more hepatotoxic than the rest. And that is something that we need to consider. But for this slide, I want you to remember hypoglycemia, similar to sulfonylureas, and be familiar with the names. All right, so let's go back to my slide. Here we have the sulfonylureas, similar to sulfonylureas, and the incretin. Incretin, what is going to do? Increase the insulin. So let's go to the incretin. In the incretin, we have, this is very highly coming for NCLEX. Bieta, the Bieta is the hexanatide. So they're going to give you both names actually. But this incretin, what is going to do is increase the insulin. Okay? All right, so here we have used in combination with other hypoglycemic agents and metformin to reduce the elevated fasting and postprandial episode. Reduce the glucose because it's increasing the insulin, right? This is going to be taken 60 minutes before meals. 60 minutes before meals. Incretin, 60 minutes before meals. The rest in 30 minutes. All right, so under this incretin, we have the Bieta. We have, this is going to be the DPP4, that is an enzyme. This enzyme, what are going to do is, the pathophysiology is a little bit complicated here, but the what is doing the enzyme is to block the to block the degeneration of the insulin. So insulin is going to still elevated in blood. So that is the DPP4 inhibitor. And that is what is an incretin. It's part of the incretin. All right, so we have the sitagliptin. So Januvia, suggested name, I don't know, Januvia. This Januvia, they are going to be used alone or in combination. This is typically question for NCLEX. And here we have the GLP and the GIP. So remember, I'm going to go back to my slides. And you see here the incretin, we have GLP-1, GIP, and DPP4. So don't lose the perspective. So let's go back. And here we have, we already talked about the DPP4. And this is actually is going to be the ELP and the GIP. So summary here, use alone or in combination. Combination with what? With other oral antidiabetic medication, never with insulin. So it's telling combination, okay, combination. You cannot combine with everything. You need to combine only with the oral antidiabetic medication. Again, they are going to produce hypoglycemia. So mostly all of these are producing hypoglycemia, except one that we are going to see now. Okay, so here we have another thing that I forgot to put it here as a remark, is the upper respiratory infection. Upper mechanism of action, we don't know. Upper respiratory infection is related to this Januvia. Januvia is using alone or in combination, but not with insulin. Okay, so let's keep going. So then we have increased the insulin, the group that we already talked. And now I'm going to refresh a little bit here, just a moment. So we have insulin secretion, sulfonylureas, similar, and incretins. So we already talked about that. So the next we are going to talk about is the diminution of glucose. Okay, so who is doing that? We are going to see the metformin. Oh, this is high super geo in NCLEX. Metformin and that thiazolidiniones. They are going to put you these names in NCLEX, but you need to remember the son. Rossi and Payo. Rossi and Payo son are actually thiazolidiniones. Okay, let's start with the metformin. And the metformin, they have very much many considerations. Metformin is glucophage. Glucophage is the first line. It's like when you have hypertension, the first line is thiazides. When you have diabetes, the first line is the metformin. So what it's going to do is increase the insulin sensitivity. So what it's going to do is to decrease the glucose in blood. First thing, question for NCLEX. The most common side effect of metformin is diarrhea. Diarrhea. We got it? So please open eyes, open ears. Metformin, the most common is diarrhea. Second, we need to remember that produce lactic acidosis. This medication has the tendency to produce more lactic acidosis. So, but it's okay if the patient is having some lactic acidosis, can be reabsorbed. The problem is that if the patient decides someday, or say, I'm going to do all the exercises I didn't do in the rest of my life, or in my past life, they are going to do so much exercises that the lactic acidosis are going to be really high rocketing in the body. Produce cramps, produce what else can produce acidosis, means metabolic acidosis, okay? And the patient can die from coma. So another thing that metformin is the malabsorption of vitamin B12. So they can lead into anemia. The mechanism is just because block the doors. The doors are going to be locked. The locks are going to the doors for the entry absorption of the intrinsic factor attached link to the vitamin B12 in the intestine is going to be blocked. So it's calcium. So calcium is the thing is going to block that. So we don't want to talk about that. Just remember that can produce a deficiency of vitamin B12. Produce hypoglycemia? No. See, that is the only one. So metformin is not going to actually produce hypoglycemia if you give it in therapeutic levels. Okay? The rest is going to be produce hypoglycemia. Okay? All right, so one super NCLEX here is the metformin that can produce GI upset. So that means cramps, flatulence, it's gassy, pain, some gastritis. So, and for that is because the metformin. If you cannot avoid that, you can take it with meals. So the bioavailability is still going to be okay. But it's preferable not to eat it with food. But if there is so GI upset, then you need to take it with food. Okay. Phenytoin. We was talking about phenytoin many times already, and we are going to make a summary when the time is coming, as in the next class. Phenytoin is anticonvulsant and is going to decrease the effect of metformin. All right, so we have the other group of decrease the glucose is the thiazolidone, so it's Pio and Rossi. Rossi Pio, or Pio Rossi, or whatever you want to remember. And these guys are going to produce diminution of glucose. And what is characteristic about Rossi, that is they have liver problems. Okay, Rossi is the Rosa, right? So Rossi is the, just to remember, Rossi, Pio, and these guys are going to have some problems with the liver. So hepatotoxicity. All right, so another thing that is very smart from the body, right, is that the alpha glucosidase inhibitor against. So you need to remember this? No, I want you to remember just the glucose absorption. So remember that the previous one diminishes the production of glucose from the liver by glucogenolysis, glycogen into glucose, or gluconeogenesis, proteins into glucose. So those are going to be inhibited at the level of the muscles and at the level of the liver. That is the previous one. Now we are going to talk about the decrease of the absorption of glucose, and that is the acarbose and the miglytol. Acarbose. So please, you must be familiar with this because this is always endless question. So diabetes is high yield, one of the highest yield topics on the NCLEX. Glucose absorption, we have the acarbose and the miglytol. We can create next time. I'm going to, I just compile everything together, but my mnemonics are going to bring it up in class in the next lecture and during the after class. All right, so we have the acarbose and miglytol. All right, so what they are going to produce is that prevent the digestion of carbohydrates. Think about it. So prevention of digestion of carbohydrates. So the carbohydrates are not digested. So they are big. So that's why they cannot be absorbed. But if they are big, if they cannot be absorbed, where they are going to be? They stay in the intestine, correct? And if they stay in the intestine with high concentration and they cannot be absorbed, what happened? So high concentration, remember again. So the lumen, high concentration, outside the lumen, low concentration. The glucose cannot, the carbohydrate cannot pass. So what is going to try to do the body? Try to equal concentration from inside and outside. What is happening is the water starts to try to get inside the lumen in order to dilute the excess of carbohydrates that was not digested. So what is the consequence of this? Is the diarrhea. That is question for NCLEX. And that is what you need to remember, the acarbose and the miglytol. Acarbose and miglytol. Another thing that we have here, precause. Precause, if you relate that with the word precause, it's like too early, right? This is going to take this medication need to be taken with the first bite of each meal. So it's another, so there's two on this, sorry, I said one is two. So this is going to be for the first bite of each meal. Another high yield. Here we have the head, we have green. Well, I cannot make more remarks. And the last one, just to finish the diabetes 1 and 2, we are going to talk about glucagon. So amylinomimetic. Do you need to remember that? No, just glucagon. And you need to be familiar with the pramlintide, pramlintide. So what they are doing is suppress glucagon secretion, okay? And again, all of these guys are going to, so what they are going to ask you for this medication is that they can treat hyperglycemia in type 1 and type 2 diabetes mellitus. So that is one of the latest. And there is another one that is the sodium glucose pump that is not in the curriculum, but is already coming from the current of medicine in 2017. So that is not in this moment in the lecture and the course and the curriculum. Okay, so what we need to remember here is hypoglycemia. So mostly all these agents for antidiabetic are going to do hypoglycemia. We have anti-hypoglycemic agents. So remember, the patient is hypoglycemic. The patient cannot take sugar because he's not conscious. So we need to keep on glucagon. Glucagon subcutaneous, intramuscular, or IV is going to respond about 5 to 20 minutes. And these treat hypoglycemic reactions. Hypoglycemic diabetes mellitus and the procedures like endoscopy, they are going to provide, so because the patient cannot drink or eat anything because endoscopy, right? The patient is semi-conscious. and they cannot take any PO, so they are going to use the glucagon. Okay. All right. So that is about for diabetes. We are going to talk about the psychotherapeutic drugs. I know this class is big, but let's try to do it as easy as we can. All right, so please think about it. This. So turn the page, and we are going to start a new, totally different topic. Okay. All right. So psychiatric disorder. So psychiatric disorder. What we are going to do is we are going to. There's two groups: anxiety disorder, the anxiety disorder that is included the anxiety itself. So anxiety disorder, the big umbrella. Under anxiety disorder, there's anxiety itself that is being treated as considered under this group of anxiety disorder. We have affective disorders. Affective disorders, we are going to have, for example, the schizophrenia. We are going to have the depression, or we are going to have the the well, okay, it's just skipping on my head. Okay, let's start with anxiety disorders. We have anxiety and fear. Anxiety, affective disorders, we have inappropriate emotions. All right, so let's keep going. So we are going to start with anxiety disorders. In anxiety disorders, we have anxiety, phobia, panic disorders, OCD, that is obsessive compulsive disorder, and the post-traumatic syndrome disorder. So those are anxiety disorders. So you know what is the difference between anxiety and stress. Stress, you know how to resolve the problem. Anxiety, you have a problem, but you don't know have idea how to resolve. That creates anxiety. Okay, so that is the difference between anxiety and stress. And then we have the affective disorders. In affective disorders, we are going to be, that's bipolar is what I was trying to say. Affective disorders are the psychotic disorders, and mood disorders. Psychotic, schizophrenia, and mood disorders, depression, and bipolar. Okay, so please, first of all, we need to remember what psychotic. Psychotic is a person who has hallucinations and delusions. Okay, and schizophrenia, and this is going to be a totally fracture of the reality between you and the real world in front of you. So you lose totally contact with that. So what happened? You live in your own world. Okay, schizophrenia, and we have depression, and that is one thing. When you have schizophrenia, all the neurotransmitters are going to be increased. Mostly are going to, it's like very high neurotransmitters. Depression is on the other side, the opposite. All the neurotransmitters are going down. Okay, and we will see that now. So in psychiatry, we have three major neurotransmitters. Dopamine is the reward hormone. Okay, serotonin is the reward and happiness hormone. So it's the mood hormone. Dopamine, for example, when you smoke a cigarette, or when you have a drink, or you have some food that is very tasty, and you like it, dopamine. Your dopamine is going up. Serotonin is your mood. Your mood, for example, I would say women in PMS, the serotonin are going to be very low. So that's why they have some changes on their mood. And we have the norepinephrine that is being used. What is the difference with adrenaline? Adrenaline is going to is, first of all, the adrenaline is less potent than the norepinephrine. So adrenaline have less adrenergic effect on the adrenaline receptor than the norepinephrine. Less. But so the norepinephrine is more potent. It's more potent. It's more potent. But what happened with the norepinephrine? Norepinephrine is going to last shorter. Adrenaline is going to last longer. So that's why we use adrenaline mostly in the pharmacology than norepinephrine. But we are still using norepinephrine when the patient is in shock or cardiac arrest. We are going to use norepinephrine, and this is the last source. We are going to try to make the patient come back. from the shock. And that is the levo fit. So that sounds like a live or death, right? Live or death. So that is the name, that how you can remember the levo fit is the norepinephrine. Okay. All right. So I'm not let me see the synopsis is I have the video, but just to yes, I'm going to see if I can pass the video. Just a moment. It's just 1 second. Today is a little bit longer, I know. Okay, so if you see here, this is the we have the axon, and this is the dendrite. So this is the synaptic space or synaptic gap. So what we have here is the neurotransmitters. Can you see the electrical impulse coming? It's like waves of ocean, and each wave are going to push more distally this way the neurotransmitters. So these could be acetylcholine or adrenaline, dopamine, GABA, glutamate, etc. So they are going to be released. This is the axon terminal, and this is the dendrite of the next neuron. So there are the receptors, dopamine receptors, GABA receptors, whatever receptor you have. So some of them are going out. So 100% of what is coming out, not everything is passing to the other side. Some of them, first of all, and then the electrical impulse is going to continue to keep transmitting that. So if you see here, some of these neurotransmitters are going to come back. That is normal. That is what is really happening. And some of these are going to come back. Some of these are going to come back. And when they come back, they get inside the axon again and make the vesicles in order to wait the next electrical impulse. So there is 3 things who are going to happen, and I stopped the video because I want just to show you this. Some neurotransmitters are going to pass. Some neurotransmitters are going to re-enter. That is what we call the reuptake. And some of them are going to be destroyed in the gap. So there is 3 things that can happen. Neurotransmitter pass to one nerve to another nerve. Second, they can return. It's called the reuptake of the neurotransmitter. And some of them are going to be destroyed here. So we have an enzyme here, an enzyme who destroys neurotransmitters. It can happen in any of the neurotransmitters. All right, so my point is this. If you have problems, you have low amount of neurotransmitter, okay? So if you have low amount of and the neurotransmitter is passing this way, so what do you want? You are going to block the reuptake of the neurotransmitter. So you have more neurotransmitter are be able to pass to the next nerve, right? And if you block the enzyme that is going to kill the neurotransmitter in the way, in the gap, that is going to increase again the amount of neurotransmitters. Others are going to stimulate the receptors. So in different ways, you can increase the levels of neurotransmitter. For example, in depression. In depression, you're going to have that. In depression, you're going to have low levels of neurotransmitters. So what you want to do is to inhibit the enzyme who destroy the neurotransmitter who pass from here to here, or to inhibit the reuptake. So reuptake inhibitors. So, and what is going to resolve that? A more amount of neurotransmitter who is passing to the next nerve cell. Okay, so that is very simple. So all right. So let's keep going. So that was taking about a minute and a half. Okay, so we start late. So let's try to make a shorter here. All right. So here we have norepinephrine, dopamine, and serotonin. And look at this. What happened? You have here no hesitation, alert, on recall. So NOR, no hesitation, memory. We have sleep, emotion, and remember, memory, SER. Dopamine, we have the dope, determination, obsession, and pleasure. I want you to remember that? Not really. So what I want is this. So attention, okay, so can you see sharing norepinephrine and dopamine? And we have anxiety, impulse, and irritable, norepinephrine and serotonin. And we have appetite, sex, and aggression. But what I want you to remember is just this: mood and cognition. So if you see, these three hormones are going to be related in order to have mood and cognition at that level. All right, so dopamine peripherally is behaving as a vasopressor, increase the blood pressure. Nervous system, determination, obsession, and pleasure. So what is doing the dopamine deficit in the nervous system? Depression and Parkinson. We are going to talk about depression today only. Excess is schizophrenia, right? So excess, so can you see, depression is the opposite of schizophrenia. A very active schizophrenia, they are going to have all the neurotransmitters elevated. Meantime, the dopamine are going to, in the depression, all that is going to be down. So what is the treatment? The treatment is going to increase all the hormones, all these neurotransmitters in depression, and to decrease all the neurotransmitters on the schizophrenia. All right. So serotonin. So again, so if you see here, serotonin is going to be peripherally GI tract motility. So they have some cholinergic effect, and they're going to have some central nervous system, sleep, emotion, remember, deficit, depression, and again, serotonin excess is going to give schizophrenia. Norepinephrine. Norepinephrine, we have deficit, depression, excess, psychotic relapse. So actually related to schizophrenia. So let's keep going. So here what we have is this. Abnormally what is happening in this problem, in anxiety and depression, all the neurotransmitters are going down. And schizophrenia and bipolar, all the neurotransmitters are going up. So there is some medication that are being used for anxiety and depression. There is some medication that are being used for schizophrenia and bipolar. So they are going to share the same group of medication. All right, so let's keep going for, psychiatric pharmacology. So we are going to see three things only: anti-anxiety, anti-anxiety. That is, this medication is called minor tranquilizers, And antipsychotic are going to be for schizophrenia, right? That is called neuroleptic. Neuroleptic is the other name. And or called major tranquilizers. Okay? Antidepressive. So those are the three things that we are going to see now. Let's talk about anxiety. Okay, so we have one guy called Smart Ben. Smart Ben is very anxious. This guy is actually nervous for everything, has fears, and Smart Ben was actually trying to do good, and he was being treated with anxiety. Smart Ben. And this guy, Smart Ben, is going to have, we have, first of all here, before to go to know a little bit more about the Smart Ben, we have anxiety disorders, anxiety, phobia, panic, OCD, post-trauma, affective disorders, psychotic, schizophrenia, a mood disorder, depression, bipolar. And if you know this, you're going to have, it's very easy just to take like a drawers on your closet what you want to talk about: schizophrenia, depression, anxiety, and that is going to be. Anxiety, we have the three cyclic antidepressants. See, because if you see this guy, so they are actually into the same location, right? Anxiety and depression. So all of anxiety and depression, they go down. So some medications for depression can be used for anxiety. And some medication for anxiety can be used for depression. Why? Because they are going to, this is what is the problem. We want to increase, right? We want to increase the, because in these problems, we have the neurotransmitter lower. Okay, so let's keep going. Anti-anxiety, three cyclic antidepressants, SSRI, we have that guy is the selective serotonin reuptake inhibitor. Now makes sense what we was talking in the video. Now let's keep going. Here we have the MAO inhibitor. This is the bad guy. This guy doesn't want to be with anybody. MAO inhibitor is actually get really the body get upset when you have some combination. So tyramine, alcohol, cheese, wine, etc. and other this medication. If you give this with this medication, they are going to probably produce hypertension. All right, so let's keep going. So we have atypical antidepressants, and the queen and the king for anti-anxiety is the benzodiazepines. Smart Ben. S, M, R doesn't exist. A, atypical. So S, smart, tricyclic. So smart Ben. So that is how you can remember anti-anxiety. And here we have a few things that you must know, please. I'm going to make a summary. All right, so we have the names. I don't need to read it, but we have here the selective serotonin reuptake inhibitor. What it's doing is increase the serotonin. You can read out there too. And the fluoxetine, Prozac, fluoxetine. The OCD is OCD of obsessive compulsive disorder is under anxiety. So this is the drug of choice for the fluoxetine, obsessive compulsive disorder. Okay. Zoloft is very common, the sertraline. MAO inhibitors, they don't like to be with anybody, because they produce some reaction, and that is the hypertension. Another high yield, please, for NCLEX is this, the venlafaxine. Venlafaxine. This is long lasting. Venlafaxine. So this is lasts about 24 hours. So it's being used as a typical antidepressant is the DSSS. Mechanism of action is unknown. All right, so here we have the benzodiazepines. So you benzodiazepines, you have your Mercedes-Benz, right? Your Mercedes-Benz. Your Mercedes-Benz is very go fast, your Mercedes-Benz, right? So that means that these benzos are going to have fast action, okay? You know that it's a depressor, right? Because it's going to increase GABA. GABA is a neurotransmitter, an inhibitor neurotransmitter. So nursing considerations, of course, you cannot take it when you are going to work, right? So, or you're using some machinery, for example, right? I'm going to make emphasis in the benzos right now because the rest is coming from, again, in antidepressant. Remember, anxiety and depression, they have similar medication. The only difference is going to be the benzos specifically for anti-anxiety. All right, so we are going to clarify that in a few moments. So we have serotonin. Serotonin is going to be a serotoninergic syndrome. That is when you have too much serotonin. So this serotonin is not going to take, it's not going to make effect right now. It's going to take about a week or 2 weeks. So the patient start to desperate, feel bad, and they start to take extra pills, and they are going to have the serotonin syndrome. Serotonin syndrome, they are going to, for example, they are going to take, for instance, TCA, that tricyclic antidepressant. What is going to do? Increase the serotonin, right? They are going to be MAO inhibitors. One of the mechanism of action is to increase the serotonin too. So you have excess of serotonin. Serotonin have, as I mentioned, a cholinergic effect. So what is going to be the side effect? Diarrhea. Diarrhea, right? Cholinergic effect is going to increase the motility. All right, so let's keep going. We have MAO. MAO, we have OH, means orthostatic hypotension. But when you mix with other medication, they can produce hypertensive crisis if they use it with tyramine. Tyramine, food, that wine, cheese, etc., or other antidepressant or sympathomimetics. All right, balancing mean, we have insomnia and headache, hypertension. So what you need to remember is insomnia and headache nursing considerations. Okay. All right, so here we have the cholinergic effect. So, all right, so that's what we said. Let's talk about the benzodiazepines. Benzodiazepines, we have the actions stimulate release of GABA. GABA is an inhibitor. So we have two types of medication. Please remember this. We have sedative and we have hypnotics. Very important. Sedative. Sedative is make you calm. Hypnotics, medication who make you or induce you to sleep. So the benzodiazepines mostly are sedative. In higher doses, they can lead into hypnosis or hypnotic effect. But the dose that we are looking for in benzodiazepines is a sedative effect. Okay. All right. So in addition to that, they can be used as anticonvulsants. For example, diazepam. Somebody is having convulsions, seizures. Immediately intramuscular IV. IV is difficult. Intramuscular is going to be the diazepam. The patient is going to come and stop the convulsions. A convulsion means lack of blood supply to the brain too, right? So that's why it's an emergency. Anti-anxiety agent, sedative or hypnotic agents. So in lower dose, sedative. In higher dose, hypnotic. Preoperative, sedative, conscious sedation. For example, endoscopies, you need to receive some orders during the endoscopy. So they don't want to make you sleep completely. So you are going to be semi-conscious and they are going to start giving orders on that. Side effects of the benzodiazepine. So this is extremely important. Benzodiazepines is hepatotoxicity. Hepatotoxicity. I'm giving you the tips, the clues, etc. for what is most likely coming or they like to ask in NCLEX. Hepatotoxicity. So what do your nursing considerations think about a little bit? You're going to have liver problems. You're going to give benzodiazepines? No, of course not, because the benzodiazepines, they go to the liver and the pill, as you see the pill of the alprazolam, diazepam, that is not going to make any effect. The effect is going to be when that pill is going to be absorbed, they go to the liver, and the liver is the factory who transform this pill in metabolic or metabolites or products that are going to be active. They are going to be active. If you have a liver problem and you take the diazepam or oxazepam, lorazepam, whatever you want, the liver is not going to do anything. So what happens? You're going to have what? Side effects. So toxicity levels. Toxicity levels. No, so another thing for NCLEX, that is in the long term, you can actually, if you take it for 1 month straight, the benzodiazepines, you need to taper the benzodiazepine. Otherwise, you're going to be awake for 2-3 days. And that is going to be very difficult to control. So please just remember, benzodiazepine, 4 weeks, continuous medication, that is going, at the time you want to get rid of that, you need to taper it, okay? All right, so patients, when you have, for example, very common to have a alcohol withdrawal, patient with alcoholism, they are going to have some anxiety. And to calm down that anxiety, to say, oh, I want alcohol, they give you benzodiazepine to calm him down, right? So mostly they are going to give it in the form of intramuscular. If the patient is vomiting and nauseous, of course, you don't want to the pill be vomit, right? So you're going to use intramuscular. Now, smokers, they actually need more dose of benzodiazepines. Smoking is going to make the liver metabolize faster the benzodiazepines. Evaluation. So how you evaluate the benzodiazepines? Of course, the patient is going to sleep better, right? And the patient is going to increase interest for certain activities. So here we have the summary of the names. So we are not memorizing them, but what I want to tell you is, for example, diazepam. Diazepam Valium is on say 15 minutes. It's going to be long period, so it's going to be almost 1 day, 2 days, about 20 hours. Then we have we have here the midazolam. Midazolam is for procedures like endoscopy, for example, bronchoscopy, for example. They are going to use midazolam. Flurazepam is long. Flurazepam, right? So PAM and LAM. PAM LAM or LAM PAM, whatever you want to know. So PAM and LAM are going to be the suffix for benzodiazepines. So we have oxazepam that is mostly used for alcoholism, for sedative for alcoholism intramuscular, lorazepam, ativan, and they're going to be about 4 to 6 hours. So the ones who are going to be long, like 22 hours, 20 hours, are going to produce hangovers. Hangovers. So, but the short ones do not. All right, so nursing considerations. Another thing so important is the flumazenil. Flumazenil is the antidote, okay? Taper after taking 4 weeks. Don't stop abruptly the medication because they can cause similar symptoms of alcohol withdrawal. Monitor LFTs because we already talked about the liver, right? Take before bed. You're not going to take it before go to school, right? OH is the orthostatic hypotension and safety precaution for driving, etc. All right. So we have this is high yield again for NCLEX is the azaspirons. Azaspirons are used for anti-anxiety too. They are not classified there because they are kind of new, and they produce no addiction. No addiction. Azaspirons is going to use for anxiety, not for depression or OCD or schizophrenia. So only for anxiety itself. So I said anxiety disorder? No, I said anxiety. So side effects, lethargy, and sedation. So the buspirone, the buspar anxiety, buspar anxiety, no additive, no addictive, no addictive, no addictive. Another miscellaneous drugs, we have the hydroxyzine. Hydroxyzine is an antihistaminic. That is a mild tranquilizer for anxiety. They're using before surgery. Can be controlled for allergic reactions. So mostly this antihistaminic is going to have cholinergic effect, right? Anticholinergic effect. Antihistaminic, anticholinergic effect. So they are going to produce dryness of the mouth, throat, nose, etc. All right, so that is about anxiety. Any questions so far? If you want to stop the webinar, we can stop if you want that, but otherwise we can continue. So I want you to raise your hand. So let me see if I have some. So I cannot open the microphone. They changed the format here, and I don't know how to open the microphone. Joanne, can you hear me?
Yes, I can hear you.
Can you hear me go? Okay, because I hear you really low.
Yeah.
The volume is okay?
It's good.
Okay. And let me see if I get David, but I cannot hear him. All right, so let's continue. Thank you for staying. All right, so psychosis. Psychosis, we have disorder, ability to interpret the reality. Okay, so we talk about, all right, psychosis. The most important thing is that there are going to be environmental factors and genetic factors. And psychosis is going to start with negative ideas and hallucinations. That hallucination is you see something that is there. You can hear something that is nobody here, only you. You feel something walking in your skin, or that nobody see anything over the skin. That is hallucination. And the illusions is when you have a fixation of idea. We already talked about that. Affective disorders. So we are going to divide in schizophrenia and depression. Simple, right? Anxiety, all these guys, we already talked, phobia, etc., panic attacks, all these OCD, very common there in anxiety. Psychosis, we have schizophrenia. Mood disorders, we have depression. Bipolar is kind of questionable here because bipolar can be here or can be here. Bipolar because they are having the two phases, right? The depression and the maniac depressive, right? All right, so let's keep going. So that is the definitions of hallucinations and delusions. Okay, so that's what we just mentioned. Here we have the classification of the antipsychotic agents. We have typical and atypical, typical and atypical, typical, atypical, typical and atypical, antipsychotic, typical and atypical. The typical, we have the phenothiazines and the phenothiazines. So these are going to have, these phenothiazines are the first ones. So we have the chlorpromazine, chlorperazine, promethazine. Those are the phenothiazines that have more side effects. Reduce psychosis, signs and symptoms without sedation. And these phenothiazines are going to be the first ones who are being released in the market. Then we have the no phenothiazines, alloperidol. So what is doing here, the alloperidol can produce extrapyramidal signs and symptoms. So that means the pseudo-Parkinsonism. Now, so this is the typical. Typical, we have, this is the old treatments. The atypical, we have the aripiprazole, Abilify, it's long-lasting, olanzapine, Ciprexa, risperidone, that is using for autism too, and the quetiapine, that is actually used for schizophrenia. That is all this guy for schizophrenia. All right, so we are going to see drug interaction with antipsychotics. So what is antipsychotics? You have too much of what? Of neurotransmitters. So what you want to do is to decrease the levels of neurotransmitters, okay? So if you decrease the neurotransmitters, you're going to have, for example, it's going to have a summation of action. So you're trying to depress the patient in order instead to stimulate the patient. So because too much neurotransmitters is going to stimulate the patient. And in schizophrenia, what we want is the opposite. We want to decrease the what? The neurotransmitters. So if you add tranquilizers in the top of that, or antihistaminics, or alcohol, or essentials wort, so they are going to make summation of effect. And you don't want that. All right, so decreased effects of antipsychotic, we have the phenytoin that these are medications we are going to talk later, but phenytoin is the one I really want you to start get familiar because there's coming question for NCLEX all the time. All right, antipsychotic, we have first class, are the older class for acute process, so those are the typical. The typical are going to be the chlorperazine, is low potency, and the alloperidol is first generation again. So let's go back to our chart very fast. So, all right. So this is going to be first generation, second generation. So I have it there. So yes, please, yes. Yeah, this is the chart actually. So we have typical, we have chlorperazine and allopurinol. So we have the phenothiazines and no phenothiazines, right? So the first is chlorperazine, first generation, second, and the first generation again, the alloperidol. We have the typical, atypical, typical the first generation, atypical the second generation. We have, this is the new ones, the clozapine, olanzapine, quetiapine, risperidone, and we have the dopamine system stabilizers that the mechanism of action is unknown. Is the aripiprazole. All right, so let's keep going. So here we have the typical, what is going to do mostly is extrapyramidal symptoms. We have neuroleptic malignant syndrome that is going to give you hypertension. We are going to see that now. We have clozapine, olanzapine, quetiapine, and risperidone. Those are the typical, the new ones, are weight gain, not fluid, but fat. Clozapine, especially the clozapine, we have agranulocytosis, that means bone marrow suppression, and extrapyramidal symptoms. So this is the new ones, right? So pharmacokinetic, pharmacodynamic should be better. So we have here less dose, less side effects, and proof of that extrapyramidal in the typical is plus, plus, plus. The atypical is only 1 plus. Just to pay attention on that. All right, so let's keep going. So we have here the antipsychotic side effects. antipsychotic, antipsychot. Anti is anticholinergic, dry mouth, agranulocytosis, neuroleptic syndrome, temperature. So the temperature is going up with the neuroleptic syndrome, temperature. Inhibit gonadotrophin hormone. So these patients have sexual dysfunction, okay? Photosensitivity. So these are NCLEX, all these antipsychotics, very high yield. Prolactin, PP, prolactin, female and male, they can produce milk. Male, we have breast, but a little bit of tissue, gland tissue, okay? In female, from all the breasts, 85% is fat. 50% of that volume is going to be glandular tissue. Okay, side effects, extrapyramidal or pseudo-Parkinsonism. Y is yellow skin. C is constipation, anticholinergic, right? Urinary irritation, okay, anticholinergic. Hypotension, obesity, and tardive dyskinesia. Tardive is late. Tardive means late. This means dysfunction. Kinesia means movement. Is a long-run side effect of these antipsychotics that will produce some problems for movement. So the patient becomes like a statue, don't move. So that is that. So we have, in addition to that, you can just summarize a little bit here, sludge, if you want to use this or this one. I just prepared this one. And we have sedative, lethargy, urinary retention, dry mouth, GI upset, energy loss. Neuroleptic malignant syndrome. So what is this? Is an idiosyncratic reaction. So we don't know where it's coming. So it's coming especially for medication. Okay, sorry. Well, we know it's coming. It's idiosyncratic. That other one is idiopathic. It's different. Idiosyncratic reaction is an effect produced by medication. So often occurs after the initiation of neuroleptic treatment. So remember what is neuroleptic? Neuroleptics are going to be antipsychotics, right? Neuroleptic is the same antipsychotic. So increased temperature, heart rate, blood pressure, rigidity, and alteration of level of consciousness. So what is the treatment for this? They are going to ask you, what is the antidote for neuroleptic malignant syndrome? There is none. There is none. There is no antidote for this. So what is going to be is general support. If you have fever, they are going to try to give you something to decrease the temperature. If you have heart rate, they are going to try to diminish the heart rate. They say with blood pressure, their muscle relaxing to. The problem is the rigidity. That is the major problem with the neuroleptic malignant syndrome. Why? Because they can totally paralyze the diaphragm and you die from asphyxia. Worst scenario, stroke and death because of the heart pressure, etc. All right, so stop smoking because shorten half-life of the drug, and we will need to increase the dose. Okay. Depression, we are going to talk, we already talked about schizophrenia. Yes, we passed it already. Remember the phenotype, typical, atypical. Okay, so those are similar for the, well, let's not similar, it's for schizophrenia. Let's talk about depression and bipolar. So here we have, in anxiety, we have our friend Smart Ben, right? But actually his name is Ben Lee. Ben Lee, Smart Ben Lee. Smart Ben is become anxious, and then Smart Ben Lee is actually when we it's a person who become depressed. Let's put it that way. Smart is going to be the same for anxiety. So remember all the classification we was talking. So antidepressant, we have TCA, so the same, I'm using almost the same. There is some changes on the names of the medications. We are going to see that. So, all right, so we have TCA, we have imipramine that was in the previous one. This is 2 in the clomipramine, the SSRI, fluoxetine, and paroxetine. Here we have something different already. This is the isocarbo, is with R, carbosacid, and the phenelcine. the MAO inhibitors. So what they are going to do is to increase the levels of medication, of the neurotransmitters. So before this, because we are going to focus on this, we have just a moment. Okay, so the same side effect that we was talking before, the tricyclic antidepressants have seizures or the arrhythmias. So that is what can kill the patient. That is arrhythmias, tricyclic antidepressants. SSRI is the serotonin, seizures and dysrhythmias. They can kill the patient with that. And MAO is going to take about 2 to 5 weeks. And antidepressants, about total in general, it's going to take about 6 full weeks of effect, full effect. So 6 weeks for having full effect. Okay, so let's talk about the antidepressant, the bupropion and the nefadion. So this is, and those are headache, insomnia, and hypertension. So if you see here, it's SMART, S-M-A, where is that? R is silent, and T is the tricyclic antidepressant, SMART. Lithium, SMART Li, for depression. They can be used for bipolar. They can be used for migraines. It can be combined with tricyclic antidepressant for resistant depression. Work in 70% of the cases. They are going to, that is the mechanism of action. The mechanism of action is MOA, it's not MAO. It's mechanism of action, block second messengers, prostaglandins, for example. And here we have the dose that is coming always for NCLEX, 0.6 to 1.2 milliequivalents per liter. Loops diuretics can increase the levels of serum of lithium. Okay, so this is a must we need to remember. We are almost to finish. We have lithium can produce heart block and diabetes insipidus. Okay, so antidepressants, we have the what we was talking here, the first generation. We have the tricyclic antidepressant. We have all the names that we was remember here, and please remember suicidal ideas. We was talking about these guys, the first generation. If the patient is so depressed that they cannot do anything, but if you take the medication, after a while they are going to start feeling better, so they can make effective his suicidal idea. So you need to be careful, and that happened in between 2 weeks and 4 weeks. Okay, so this can the patients can die from arrhythmias. So be careful with that. All right, so have anticholinergic effects that I remember somebody of you remarked the last class, and we have increased warfarin effects. Increase the warfarin effect. That really increase the warfarin effect. All right, okay, so we need to take for 2-3 weeks to start to make effect, and to have full effect about 2 to 3 months, and to reach the therapeutic range. Take every day. You cannot stop to take the medication. One day or whatever you want. No, every day. No stop suddenly, because they can produce some rebound effect. So you become more depressed. Suicidal risk increase the first month of the treatment. Second generation is going to be the SSRI. We already talked about that. And the third generation is going to be the MAO inhibitors. Okay, guys, thank you so much. Let me see if I can open microphones. I know that was late, and thank you, David. Thank you, Joan. Joan, can you hear me?
Yeah. Thank
Okay.
you.
So thank you so much. So I will record it and post it. Oh, I can hear you, David, now. So thank you for coming. I really appreciate you be present today. Gracias. Buenas noches.
Good night. Thanks.
Bye.